we started off talking, or we ended class yesterday talking about the difference between rearfoot varus and rearfoot valgus. Remember that? And how we had everybody stand up and we actually looked at their rear foot posture. Yeah? Okay. So obviously what we were looking at there was obviously a form of essentially biomechanical abnormality in the foot, right? And biomechanical abnormalities in the foot, guys, can really be, symptomatic or asymptomatic, right? So honestly, guys, some people might look at this and wonder, why in the world is it important for us to learn about these in the first place? Who cares if the patient's in rear foot valgus or rear foot varus, if they pronate? Like, who cares about that? Well, the reason why that's important, guys, is that ultimately there are times where if we can identify these biomechanical abnormalities, right, and treat them, we can actually make people significantly better. Okay, particularly in people that have ankle, maybe Achilles pain and or foot pain, right? It's extremely important to be able to identify these and identify them, particularly when people are having symptoms and or pain, right? And be able to correct them to see if we can actually alleviate symptoms, right? So ultimately, knowing these different pathologies is going to help right? Either, to treat the patient, refer them, and or do nothing, right? People that have some of these deformities that we're going to talk about, ultimately, there are a good number of them that they're not symptomatic, right? Generally speaking, we work with a very young and healthy population, and the vast majority of people that actually have these deformities they're not going to cause symptoms, right? However, that does begin to change, particularly if we have patients that are a little older. These abnormalities can actually become quite symptomatic in some people and cause quite a bit of pain. And so obviously in those people, if we're able to correct them, we can really help people. We can have obviously a lot of positive consequences for the patient. So you guys remember, right, when talking about these, right, a lot of these deformities are generally going to take place either in the rear foot or they're going to take place in the forefoot, right? Because those are the two most mobile segments that we have. The midfoot, usually because of the fact that, it's made up obviously of the tarsals and it's relatively stable, we generally don't see very many biomechanical abnormalities in the midfoot. Okay, guys, first one. First of all, can you guys hear me okay? I want to make sure my sound isn't janky.
Yeah, we're good.
We're good? And the other thing too, guys, my internet's been crazy. I lost it all weekend, and then this morning it went out again. So hopefully we'll get through today's lecture without my internet going out. But if I lose you, we'll figure out a way for me to find you somehow again and get back on. So, all right, hammer toes, okay? If you've ever seen these, who's ever seen hammer toes? So this is essentially a contracture of the toes, okay? This almost kind of looks like the toes are curled, right? And if you look really closely at this, you're gonna find that MTP, if you can see my finger, the metatarsal phalangeal joint, so that distal phalanx is gonna be super extended, right? And that IP joint is gonna be flexed. It's gonna look like this, okay? It's gonna be a hammer toe. All right, so I've got, MTP joint hyperextension and flexion of the IP joint, okay? So what causes this, okay? This is generally most often caused by contractures within the intrinsic muscles of the foot, okay? So the interossei and the lumbrical muscles in the foot. So ultimately, when I say contractures, these muscles in the foot become shortened, and they essentially shorten and become tight. Okay, when those muscles shorten and become tight, people actually develop an inability to both abduct the toes and maintain the toes in a position of extension, right? And so ultimately what happens is we get this hammer toe deformity, excuse me, geez, sorry, and the toe looks curled, okay? So once again, the hammer toe is characterized by hyperextension of the MTP joint and flexion of the interphalangeal joint. All right. Usually, I mean, in our population, we would leave this alone. And I wish that I could find a picture for you guys, but when I worked at TRIA and I was kind of helping in the podiatry clinic, it's super crazy to actually see. There are times where they can actually do surgery to fix hammer toes. And what they'll actually do is they'll actually put metal rods into the toes to actually straighten out the deformity. And that patient will actually come in for a post-op check, and it's nuts because you look at them, they take off their post-op dressing, and their toes are literally there, and they have metal rods with hooks on the ends sticking out of their toes. It's bananas if you've never seen it. It's absolutely bananas. But yeah, and then the podiatrist just comes in and pulls them out. Crazy stuff, right? No big deal. I'm just going to pull these metal rods out of your toes, right? So fun stuff. All right, Morton's toe. Okay, and here's the deal. As you guys obviously are in the clinic, particularly as you're gaining experience with taping, I would encourage you guys to start looking for these in people, right? As you spend, the vast majority of your days staring at feet, which you will, right? I highly, highly encourage you guys to go through these deformities and start kind of, being able to identify them. Okay. You know what I think would actually be really fun for this class? What if we created a bonus pool for this class and essentially tried to see who could identify the greatest number of foot deformities in patients, right? And then awarded bonus points based on that. That'd be kind of fun, right? I feel like that would actually be potentially semi-useful and helpful. Okay, but Morton's toe, right? This is characterized by the appearance of the second toe being longer than the first, right? So if you look at someone's foot, it looks like the second toe actually kind of juts out more and is longer, right? In reality, right, though it seems like, okay, so just your second toe is longer than your first toe. But generally speaking, what actually causes this is actually a difference in length of the metatarsal itself, right? And not the phalange. So generally speaking, the first metatarsal is longer than the second in this case. And the way that we actually tease that out clinically is you can go and you can actually feel the patient's foot. And what I would encourage you guys to do, right, is actually find the metatarsal heads and actually just kind of take them and just kind of look at the length. So compare 1, 2, 3, 4, and 5. And ultimately what you'll find is that on generally 1 or 2, the thumb will actually sit higher on 1 than it does on 2. Occasionally that can be flipped. Occasionally you'll see 2 is a little bit more, obviously sits higher than 1, right? So you're going to see a length differential in the metatarsal itself, right? Does that make sense? Okay, if it doesn't, let me know. I have a hard time seeing heads. You guys are very small. But if it doesn't make sense, let me know. All right, Hallux valgus, friends, the wonderful world of bunions, okay? We're pulling into Bunion Junction, super fun. It was a Schoolhouse Rock joke, but nobody got it. Will maybe got it if he smiled a little bit. Okay, so this is essentially characterized by a deformity of the MTP joint at the great toe. Okay, when I say MTP joint, what do I mean? What do I mean when I say MTP joint? One more time.
The metatarsal phalangeal joint.
Very good. So this is the junction between the metatarsal and the phalange. Who can tell me, by the way, which ray of the foot is affected in this deformity? Somebody said first ray? Okay, very good. First ray. Okay, here's the deal. Ultimately, generally with this deformity, this starts out as subluxation, right? Or, basically chronic instability of the MTP joint, generally in adolescence. But as we grow, right, and as those ossification centers begin to close and the growth plates close, what we generally see is that deformity actually becomes fixed, right? And people will actually develop a bunion and or obviously what we call hallux valgus, right? So as that deformity essentially, basically kind of becomes more permanent as we grow, that's due to actually growth plate closure as we get older. And you can obviously see, guys, if you look at this picture, how the angulation of the MTP joint here can actually affect the function of the remaining toes. You see how the 2nd through 5th toes here are just kind of shifted laterally? How that can actually create a deformity actually in the other toes, right? So In certain people, there's actually a tape job that you can actually do for this to keep the toe in neutral. But very often, once this becomes symptomatic or starts to bother someone, generally speaking, we can try things like tape jobs and other types of things, and or like toe spacers to alleviate symptoms. But oftentimes, particularly as people get older, this will have to be corrected surgically through a bunionectomy, which is actually where they go in and they shave down part of the bone and do a little bit of an osteotomy. So they shave down the bone and cut part of it out, and then realign the distal phalanx, obviously, with the first metatarsal. Kind of a groovy surgery. The only problem is that sometimes it actually doesn't work. Okay, that was fast. Okay, so guys, midfoot and rear foot mechanics. Okay, you guys remember this picture from Friday. Okay, who can tell me, by the way, why is it so incredibly important to always evaluate midfoot and rear foot mechanics? What potential effect could that have on a patient?
Tell you where their stress would be.
Okay. It'll tell you where they're, and was that Will? Sorry, I didn't see you. Was that you that said that, Will? Sorry, Bennett. Sorry. Okay. Yeah, so it could actually, yeah. So you can see if someone actually is in rear foot varus, right? That could put obviously more stress, maybe on the lateral aspect of the foot. Okay, yeah, absolutely. So they could come in complaining to you of potentially maybe lateral heel pain. Okay. Do you guys remember from yesterday? What's a way that we can correct rear foot mechanics? How did we do that yesterday?
Have them pick their heel up and set it on a soft, elevated surface.
Okay, yeah, and so what I'll try to do, guys, hopefully before class, maybe tomorrow or Friday, I'll actually try to cut like basically some foam heel lift, or probably foam or felt heel lifts, and we'll actually try this out on each other in class to kind of get an appreciation of how this can actually correct this posture. Okay, cool. So what if though, if I'm in rear foot varus, for example, okay, how could that affect my midfoot? What would you guys maybe expect to see in my midfoot? What do you think? Would my arch be normal or potentially abnormal in some way?
What did you say?
For varus or
Sorry.
valgus.
So, okay, I'm just gonna ask the question this way. If I was in, let's say I was in either rear foot varus or rear foot valgus, right? If that's the case, would my arch, my medial longitudinal arch, would that be in a neutral position or potentially not neutral?
Non-neutral.
Non-neutral. Okay, awesome. Okay, so let's say if I'm in, so let's say this is my rear foot. Okay, this is the medial side, this is the lateral side. Okay, if I'm in rear foot valgus, what direction will my heel be tipped into?
Medially.
Okay, medially. So the force is going to come from this side and my heel tips this way. Okay, so if we remember valgus, V-A-L, okay, valgus, L, lateral side is where the force comes from. Okay. Now this might put me, at least my midfoot, might put me into a pronated posture and or cause my foot to, my medial arch to fall flat. Okay, does that make sense? Okay, conversely, remember, if I'm in rear foot varus, okay, force is coming from the inside, tilts me laterally into varus. What's that going to do to my medial longitudinal arch?
Like more space between.
Okay, okay,
arch and-
okay. So I'm gonna have a higher arch then, is he right? Okay, so who remembers the names of those positions? So if my arch falls toward the floor, I'm what?
You mean like pronated or?
Yes, I'm pronated, right? So if my arch is essentially falling out of neutral toward, toward the floor, I'm pronated, right? However, if my arch obviously, lifts up, I'm in supination. So pronation, supination, pronation, supination. Okay, make sense? Cool. All right, here we go, friends. So flat feet, okay, and or being in the midfoot being in a pronated posture. Look at this picture for a second, okay? What do you notice about this picture? What does his arch look like? What? I think I heard someone say something.
There isn't one.
There is not one, okay, and or it's very minimal. By the way, if you take a good hard look at that picture, what's another thing that you see there? Look at his heel and look at his forefoot. What else do you see? And I know you're not getting obviously a complete view, but just looking at that from the medial side, what do you see?
Is it internally rotated a bit?
Okay, are you talking about the heel or the toe?
Both, I guess.
Yeah, no, so you're right, Charlie. So the heel, right, is in a little bit of rear foot valgus, actually. You can actually see it, right? It almost kind of looks like the heel is kind of falling inward a little bit in a valgus position. And what's the other thing that you notice about that big toe? Look at that big toe. Something about that big toe is kind of funny.
Yeah, I think
I think that's just a callus because of how his foot's rotated.
Okay, so the big toe, okay, he might have a little callus there, but if you look, that first ray, particularly that forefoot there, is actually so internally rotated that the lateral edge of the first toe is actually coming off the ground. So he's got a lot of internal rotation of that first ray because of the amount of pronation that he has, right? Okay, so obviously with flat feet and or what's another term for, sorry, oh gosh, what's another term for flat feet? What do we call that? It's in the title. Pes planus. Okay, pes planus, flat feet. Okay, excessive pronation. Okay, often, obviously, we can see that this is something that can contribute to altered mechanics, particularly at the ankle, right, and even at the forefoot. Sorry. Okay, now here's the deal. What's the one thing, guys, that we've already said? Generally speaking, in younger populations and younger healthy populations, are these deformities generally painful? Excuse me. What do we think? Are they generally painful?
Often non-painful for most people.
Very good, Izzy. Now, here's the deal. Why? Let's just think about an athletic population for a second. Why do you think that it would be important to potentially identify this and make sure that either we're correcting that, obviously, pes planus, and or helping them reestablish neutral by either using orthotics and or using a shoe with a nice medial arch to it? Why would that be important?
It can put stress on other tendons and ligaments further
Okay.
up the leg.
Very good. Keeping, obviously, if we change the height of the arch and we reestablish a biomechanical neutral, what we've done is we've taken stress off of both the forefoot and the rear foot in hopes, right, that we can obviously, keep those structures in neutral and decrease injury, right, by improving the mechanics of the foot. Does that make sense? Awesome
Yes.
sauce. Awesome sauce. Okay, cool deal. All right, guys, supination. Okay, supination, guys, and I should have, let me put this on the, I'm going to unshare for 1 second, guys. 1 second. I need to put this, I need to add it fast. So I should have put this up here. Oops. All right, that's better. Okay, so you guys tell me, for example, and this is obviously not a Latin class, but what is the Latin word for foot? We just kind of learned it.
Pez.
Pez.
Or-
Very good. Absolutely. Absolutely. Pez. Nice job. Okay. Whoops. Damn it. You know what? Sorry, guys, for cussing. I put that on the wrong slide because I'm a genius. Sorry, friends.
No.
What? Better. Better, better.
Perfect.
Oh, my life. Okay. All right. Perf. All right, guys. So supination, right? Or high arches. Okay. This is known as pes cavus. All right. Now you can see, okay, you can see here, obviously, this person's got a really high arch. But what do we notice about the rear foot? What rear foot position is this person in? Who can tell me? Yeah, I heard somebody say it. They're in rear foot varus, like whoa, like they've got some pretty significant rear foot varus, right? You can definitely see it, right? Okay, so obviously pes cavus, right? This is obviously characterized by high arches, right? And you can see how the ankle itself is actually slightly inverted. Do you see that? See how it's kind of rolled in a little bit? So rear foot varus obviously lifts the medial arch, but places more stress on the lateral arch as well. Okay. So obviously in supination, the arch lifts off the ground and moves away from the floor. Okay, you guys see that? And then some people, right? There are some people that are just born with high arches. They're born with pes cavus, or a supinated medial longitudinal arch. And for some people, it's not painful, right? But for other people, it is. So what do you guys think that the main clinical take home is for these deformities from what we've talked about thus far? What's the main point clinically that you guys think we've established?
If they're not having any pain with them, should we even do anything?
Right. If it's not painful, leave it alone. Okay. Good point, Bennett. What's the potential advantage that we've talked about to identifying this though, and potentially treating it in someone who's asymptomatic? What maybe could be the one benefit to that?
Prevent pain in the future somewhere else.
Okay, maintaining biomechanical neutral and at least presumably limiting pain and symptoms in the future. Okay, excellent. But if this is painful, if the patient's symptomatic and they're having foot pain, right, they're having ankle pain and or even Achilles pain, right? If you see a deformity, treat it. Let's see if they get better, right? Treat the biomechanical deformity, see if they improve, right? Does that make sense? Okay, cool. All right. And last but not least, guys, obviously rearfoot deformities, pes cavus, dang it, oh, sorry. I thought I took that out, but obviously I didn't. Ugh. All right. Okay, obviously we can, with rearfoot deformities, we actually have obviously either, okay, rear foot varus or rear foot valgus, right? We know what those are, All right. We know that these actually have the ability to also impact our midfoot mechanics. So we obviously also know that with rear foot valgus, the force comes in from the outside, causes the heel to fall in or project medially from neutral, right? And conversely, we know that with rear foot varus, the heel projects laterally based on a medially directed force. That typically also pairs with which midfoot deformity generally? Rear foot varus is typically paired with which midfoot deformity? One more time.
Supination.
Bingo. Yep. Okay. Rear foot valgus is then paired generally with which midfoot deformity?
Pronation.
Okay. Yep. Maybe generally the opposite of supination, right? Which is pronation. Okay. Awesome sauce. All right. So, yeah, nice job. So I will post this on Moodle for you guys. Guys, that's it. Okay. What questions do we have about anything that we covered today? Anything that doesn't make sense that you would like me to go back over and or explain? Are we good?
I think so.
All right. Hey guys, just really quickly, I just want a quick word of encouragement. I'm super, just to let you guys know, I am super duper happy with how quickly you guys have picked up on this. The other thing that actually really impresses me about you guys is how cohesive you guys have actually already become as a class. We've literally been doing this for maybe 3 weeks. And you're like, you guys, yeah. So my hat's off to you. Good job. Okay. So yeah, proud of you. Anything, so nothing, no other questions, nothing that you guys need? All right, sounds good. What?
Awesome.
Okay, I thought I heard, okay. Hey, sorry, Kaya, did you get my email?
Yeah.
Okay, cool. Yeah, good luck, by the way. But
Hey.
just let me know. Okay, we'll make a plan to get together when you get back, and we'll go through all this stuff. Okay.
Sounds good.
Okay. Good luck. If you need anything, let me know.
Okay, thank you.
Okay. Go get them. All right, guys. Have a good day. I'll see you tomorrow. I'll keep you guys posted about Friday. All right. I'll let you know as soon as I know something. All right.
Wait, should I just like chew your ass?
Bye.
Bye, guys. See you tomorrow.
Thanks, Wade.
Yep. See ya.
It's downstairs.